had this pregnant lady who's still under my follow-up. She delivered recently, a 30-year-old primary gravida. She had 7 years of married life. She had actually had her antenatal visits elsewhere. Um, and she was shifted to us on 17th of October for management, for further management, since her condition was deteriorating, worsening. She had no significant past medical history except for hysteroscopic septal resection, which was done in 2023 when she was evaluated for primary infertility. So in this pregnancy, her first pregnancy, at 12 weeks of gestation age, in view of increased uterine artery pulsatile index, she had been put on aspirin 75 milligrams twice daily and enoxaparin 40 milligrams subcutaneous once daily. So she was on irregular therapy with these molecules, both aspirin and enoxaparin. You might ask, why was she on enoxaparin? I agree there is no indication for enoxaparin LMWH prophylaxis in her. She just probably required aspirin. You might even ask, why aspirin 75 twice daily, not 150 once daily? So this was what she was advised before she came to us. Okay, so the problem started at 23 weeks of gestation. That's on 1st of October of this year. On 1st October 24, when she was about 23 weeks gestation age, she developed blurring of vision, which progressed rapidly over the next 2 to 3 days, so much so that she was unable to read. She was just about able to identify faces in good daylight. At this point of time, she had no other neurological symptoms like headache or vomiting, and her BP was about 130 to 136 by 80 to 85. She belonged to a doctor's family. They consulted an ophthalmologist, local ophthalmologist. He made a diagnosis of bilateral central serous retinopathy with retinal detachment. And he explained to them that occasionally pregnancy can be complicated by serous retinopathy because there is fluid accumulation in the subretinal layer. There could be some amount of retinal detachment, and the management is usually conservative, and they usually recover after delivery. So that's what was explained to them. So, and they also did some basic investigations. So her hemoglobin was 9 grams, normal MCV. Her WBC count was normal. However, to their surprise, the platelet count was 18,000. And they did renal parameters, LFT, which were normal. Urine albumin was 1 plus. LDH was not ordered. She then consulted the hematologist on the same day, and he had ordered one ANA test, and there was no spleen on ultrasound screen, splenomegaly on ultrasound screening. Diagnosis of probable ITP, immune-mediated thrombocytopenic purpura, was made. She had no bleeding manifestations on the skin. She didn't have any petechiae purpurae. She didn't have any overt bleeding. However, the hematologist decided to give her one SDP on 4th of October. SDP is single donor platelet, one transfusion, and she received 1 dose of IV methylprednisolone. We are not sure of the dose, but we were told that it was anything less than 100 milligrams. So she was given 1 dose of IV methylprednisolone, and she was started on low dose oral prednisolone. The ANA test was reported negative. The next day, on 5th of October, her platelet count was 35,000. She was given 1 more SDP on that day. Okay, then they were monitoring her blood pressure. On 7th of October, her blood pressure was 140/90 on 2 to 3 occasions. Then she was initiated on antihypertensive, nifedipine retard preparation, 10 milligrams twice daily. So these were her serial CBC reports before she was shifted to Hyderabad for further care. So on June 20, in June of this year, her baseline CBC during early pregnancy was normal. She had a good hemoglobin, her WBC count was normal, and her platelet count was 2.37 lakhs. On 4th of October, last month, when her blood investigations were ordered, when she went to the ophthalmologist with blurring of vision, the platelet was 18,000. The next day, after a steroid dose, after 1 SDP, it was 34,000. Then the next day, apparently, it was about 1 lakh. On 11th of October, it was 85,000. And then on 14th of October, it was 62,000, the platelet counts. The prednisolone was restarted just about 10 milligrams once daily was restarted at this point of time. However, on 17th of October, he went back to the obstetrician because her blood pressure started going up, and then she had some further worsening in her vision. So on that day, they repeated her CBC. Her platelets were 32,000 at her local place. So here we have a lady, first pregnancy, was well till 23 weeks. Her first clinical manifestation was visual disturbances. She had blurring of vision, which rapidly worsened over the next 3 days. At that point of time, the blood pressure was about 136 by 85, 86. She had no headache. And the routine investigations, baseline investigations ordered at that point of time revealed severe thrombocytopenia and no other abnormalities except for mild albuminuria. The urine albumin dipstick was 1 plus. So what do you think the diagnosis is? So subsequently, her BP touched 140. She was started on antihypertensives. So the first diagnosis I would consider in her is preeclampsia with severe features. She had mild anemia. She had severe thrombocytopenia, and she had retinal detachment. So of course, this is an atypical presentation of preeclampsia. She did not present with high BP or headache or pedal edema, but she presented with visual disturbances. She of course had pedal edema. So could it be lupus with nephritis and hematological involvement? Definitely, it must be a differential. However, it is very unlikely in her because her ANA was negative, because ANA has high sensitivity, and we can rule out lupus by 99% because her ANA was negative, and she did not have any other features of connective tissue disease like skin rash, oral ulcers, joint pains, etc. Could it be thrombotic microangiopathy like TTP? That is thrombotic thrombocytopenic purpura, possible. However, she had no organ dysfunction like um, acute kidney injury or liver involvement. She did have proteinuria though. So that was not considered by the treating doctors. This possibility was not considered by the treating doctors. So could she be having both preeclampsia and ITP? Possible. We always try to explain all the problems a patient has by single diagnosis, but at that time patients may have two diseases at the same time. So she could be having preeclampsia and ITP. That's a possibility. So that's what we considered when she was transferred to us on 17th. So now let's just look at some of the older diagnostic criteria for preeclampsia. So if you look at her baseline BP in early antenatal period, it used to be somewhere between 100 to 110 systolic and 60 to 70 diastolic. So when she went to the ophthalmologist with blurring of vision, on that day, her BP was maximum, BP was 136 by 86. So some of the older preeclampsia definitions, I will be now showing a slide in a minute. The diagnosis of gestational hypertension included either BP of 140, 90 or more, or an increase in systolic BP by 30 millimeters or diastolic BP by 15 millimeters from baseline blood pressures. Going by that older diagnostic criteria, she had hypertension when she first went to the ophthalmologist itself, because her systolic was 136 from a baseline of 100 to 110, and her diastolic was 86 from a baseline of 60 to 70. So you look at two case scenarios: somebody who has a baseline blood pressure of 130 systolic and that becomes 140 now, or somebody who had a baseline blood pressure of 100 systolic and now she has 130 systolic. So which one is more worrisome? So because in the patient whose BP increased from 130 systolic to 130 systolic from 100, there is 30 increase. Whereas in a patient who has 140 BP systolic blood pressure, but the baseline is 130, there is only 10 rise. So that is something we need to look at. So this is this slide shows us the diagnostic criteria over the last few decades from 1950 onwards. So if you look at in 80s and 90s, most of the scientific bodies or societies, the diagnostic criteria included the rise in BP from the baseline. So if you look at the Redman and Jeffries criteria in 1988, or the ASSHB, that is Australasian Society for Study of Hypertension Pregnancy. So if you look at that, the diagnostic criteria for preeclampsia included blood pressure of high blood pressure 140/90 or more, or increase in blood pressure from baseline, early pregnancy baseline blood pressure. That is about 30/30 systolic blood pressure increase and 15 diastolic blood pressure increase. However, after 2000, after year 2000, all the bodies, they took this part, that is increase in blood pressure from the baseline as a diagnostic criteria. They all said, all the bodies said, patient needs to have 140 or 90, 140 over 90 or more to call it gestational hypertension. And there was a reason for doing so. So in 1999 and in 2000, there were two publications. That was a work done by North et al. And Levine et al. What they did, they compared patients who had rise in BP, 30 systolic increase or 15 diastolic increase from early pregnancy baseline, but did not reach 140/90. So they looked at patients who had increase in blood pressure from early pregnancy, but did not reach 140/90, and those patients who had normal blood pressure and there was no significant increase as the pregnancy progressed. And they found that even those patients who had increase in blood pressure by 30 systolic in later pregnancy from the baseline, but did not reach 140 threshold, they had uncomplicated pregnancies. So that's the reason why they removed that part of that criteria, that that increase in systolic or diastolic from the baseline as part of diagnostic criteria from the preeclampsia definition. And not from 2000 onwards, it's been a uniform criteria that patient needs to have 140 or 90 blood pressure or more, in which is of new onset during second half of pregnancy. That you're all aware. But sometimes it's good to look at the baseline BP, because if there is, baseline BP is 90, 100, now it is 135, you know that there is significant rise in blood pressure. So you're probably dealing with preeclampsia. And if you look at some of the publication by Baha et al. About atypical preeclampsia, so there could be women with preeclampsia who don't have much hypertension, their BP readings are below 140, but they have all the other manifestations of preeclampsia and no other alternate diagnosis. So he used the word atypical preeclampsia for that. There's a publication which was published in Lancet in 2009. Okay, so coming back to our patient's clinical course. So October 1st, she started with blurring of vision. And on 4th October, she was found to have severe thrombocytopenia. So there was initially some increase in platelets to about 85,000, then it started dropping again. So on 17th October, at her local place, platelet count was 32,000, BP was 160/100. There was some further worsening in her vision. They did malarial and dengue serology. They were negative. One single donor platelet was transfused. He was given magnesium sulfate loading dose. Her antihypertensive doses were increased, and she was referred to Hyderabad to a high-risk obstetric hospital. So after she came to this high-risk obstetric hospital, the labs were like this. So on 17th October night, she was transferred to this high-risk obstetric unit. Her hemoglobin was 8.9, WBC count was 15,000, platelets was 62,000. The same day morning in the local place, it was 32, but here it was 62. Her creatinine was 0.9, LDH was a bit elevated, 724. The liver enzyme SGPT was normal. Her urine protein creatinine ratio was 8.2, and her 24-hour urine protein turned out to be about 6 grams over 24-hour urine. She had nephrotic range proteinuria. So the very next day, her platelets were 85,000. Creatinine started trending up 1.0. LDH was, however, stable. SGPT was normal. So at this point of time, The working diagnosis was preeclampsia with severe features. She had severe thrombocytopenia, nephrotic range proteinuria, central serous retinopathy, and bilateral retinal detachment. She was reviewed by another ophthalmologist who concurred with the diagnosis of central serous retinopathy and bilateral retinal detachment. He also advised, the second ophthalmologist also advised conservative management. And the fetal evaluation revealed fetal growth restriction and absent end-diastolic flow in umbilical artery. And her other tests, the coagulation parameters, prothrombin time and APTT were normal. Okay, so her BP medication were increased. The dosages were increased to Levetolol 200 milligrams 3 times daily and Nicardia 10 milligrams twice daily. Her magnesium sulfate maintenance dose was continued. So now the question is whether we need to deliver her. So she had indications for delivery because she had severe preeclampsia, thrombocytopenia, worsening of vision disturbances that could indicate imminent eclampsia. So it was decided to deliver her. Neonatal counseling was done. She was induced with Foley's and PGE1. She delivered 580 grams girl baby. The baby was dead at birth, was not alive at birth. So over the next 2-3 days on PND 1-2, her BP remained under good control. In fact, her vision started improving on PND postnatal day 1 itself. However, on postnatal day 3, she developed high-grade fever, 102 degree Fahrenheit. She also complained of dysuria and urinary frequency. This is when I first saw her this patient. This patient. By the time I saw her, they had sent a urine culture. They had started her on amikacin. She had well-controlled blood pressure on 2 antihypertensives, and her vision was recovering. So the next day, that is on PND, postnatal day 4, her HB was 7.1, WBC count was 11,000, platelets started dropping again, platelets dropped to 32,000. So she delivered on 19th October. She was induced on 18th October, delivered on 19th October. On PND 3, she developed high-grade fever. Her clinical picture was suggestive of UTI. Urine culture was sent and she was started on amikacin here. And the next day on PND 4, postnatal day 4, her platelets started dropping again. However, her creatinine was steadily improving. From creatinine of 1 at delivery, it improved to 0.7. Her LDH started rising again. Her liver enzymes were normal. So on PND4, where we generally expect improvement in thrombocytopenia and normalizing of LDH, here her thrombocytopenia started worsening again and LDH started trending up. So then it was decided to shift her to a multi-specialty hospital where hematologists and nephro multi-specialty multidisciplinary teams are available. So then she was transferred to a multi-specialty hospital the same day. At this multi-specialty hospital, I was looking after her. So on 6th postnatal day, her hemoglobin was 7.2. Her WBC count was 22,000. She was on antibiotics, amikacin, day 3 by then. Her platelets were 26. Creatinine was normal, and LDH started going up further, 1200 plus. And her peripheral smear showed 15% cystocytes. 15% cystocytes. So ANA was repeated, which was negative at this point of time. A direct Coombs test was negative. The question was, this is PND5. There are cystocytes on the blood picture. LDH started going up. So there is evidence of hemolysis, which is not autoimmune because the Coombs test was negative, and her thrombocytopenia is worsening. So the question is on PND5, are we just dealing with preeclampsia? Or are we dealing with some other issue like thrombotic microangiopathies like TTP or HUS? That was the concern. So there was some discussion whether to send ADAM-TS level 13, but it takes about 10 days in our setup. So the decision was monitor her closely and then take a decision on plasmapheresis, etc., based on the clinical grounds. We did not send the ADAM-TS level at this point of time. And the next day, PND 6, Her HB dropped to 6.9, but to our surprise, the platelets improved 60,000. Creatinine remained stable, but the LDH started going up further. Our peripheral smear showed about 12% cystocytes. So there was ongoing hemolysis. However, the platelets count started improving here without any further intervention. So we transfused her, we gave her one packed red blood cell at this point of time. And the next day, her hemoglobin was 8.1. By this time, we had her urine culture. Her urine culture grew Klebsiella. It was sensitive to amikacin. We continued amikacin. So after transfusion, her HB improved to 8.1. And the WBC count started coming down. The platelets again started coming down. Creatinine was okay. The LDH remained elevated, and there were cystocytes, 10% cystocytes on the peripheral smear. So we were still closely watching her. On the next day, on PND8, again her hemoglobin dropped. So, and then the platelets also dropped further, 20,000, and the LDH remained 1300 plus, was not improving. And her creat was okay. There were significant percentage of cystocytes on peripheral blood smear. So what are we dealing with here? So I'll just quickly recap because this is a very complex course. On PND5, she had worsening thrombocytopenia despite treating urinary tract infection. So we thought she had preeclampsia. The recovery is probably delayed because of urinary tract infection. Okay. So we transfused a PRBC on PND6, but on PND8, again, the hemoglobin started dropping, platelets started dropping again, LDH was pretty high, cystocytes were still present. So what are we dealing with? Is it only preeclampsia with severe features, which had an atypical presentation and course? PND8, within 48 to 72 hours, we usually expect preeclampsia-related thrombocytopenia or hemolysis to improve. At least it should start improve, if not normalize. The hematologist felt that she could be having both preeclampsia and ITP, but ITP could explain her thrombocytopenia, but that does not explain persisting hemolysis, persisting microangiopathy, because she has dropping HB without any overt blood loss. She had cystocytes on blood picture and high LDH, which were supporting the diagnosis of hemolysis. So is it sepsis with the DIC-associated microangiopathic hemolytic anemia? She had urinary tract infection, but she was on good antibiotic, which was even the culture revealed that the organism was sensitive to the antibiotic she was on, and she had no other features of sepsis. Her fever improved, urinary tract symptoms were slowly improving. She didn't have tachycardia. She was not looking septic. So this was very unlikely. Is it lupus? Lupus is definitely one among the differentials, but ANA done twice was negative. So are we then dealing with the TTP-HUS spectrum, uh, thrombotic thrombocytopenic purpura or hemolytic uremic syndrome spectrum? Or is there underlying APLA besides preeclampsia? But the presentation is not really, APLA again needs to be considered in the differential antiphospholipid antibody syndrome. But such severe thrombocytopenia, the proteinuria of 6 grams plus is very unlikely to be because of APLA in the acute setting. But these are all the differentials we considered at this point of time. So what is thrombotic microangiopathy? So for some reason, in the microvasculature, there are a lot of thrombi formed. So these yellow ones are the thrombi formed. And when the RBC pass through these clots, they get squashed and destroyed and they get fragmented. So all these fragmented RBC are called cystocytes. So microangiopathy, thrombotic micropathy is nothing but for some reason there is abnormal clot formation in the microvasculature, and these RBCs, when they pass through these clots, they get squashed and destroyed. So you have hemolysis, you have cystocytes in the peripheral blood smear. These fragmented RBCs are nothing but cystocytes. And there is hemolysis, so LDH goes up. There is clot formation, so there is thrombocytopenia. There is excess thrombocyte platelet consumption. There's thrombocytopenia. Okay. So what is TMA, thrombotic microangiopathy? Thrombotic microangiopathy is defined by a pathological pattern. There is endothelial injury, endothelial swelling, and there is peripheral thrombocytopenia. There is mechanical hemolytic anemia. So patient would have anemia, evidence of hemolysis in terms of raised LDH, very low haptoglobulin, and cystocytes on peripheral sphere, and the patient will be Coombs negative. And there should be some evidence of organ dysfunction, be it uh, neurological, in neurological, cardiac, or hematologic, etc. So there are various causes of thrombotic microangiopathy, pregnancy specific like preeclampsia and HELP syndrome, or pregnancy non-specific like TTP, thrombotic thrombocytopenic purpura. Uh, they usually present with hematological, neurological, plus minus cardiac involvement. Occasionally, they may have renal involvement. And this is usually associated with reduced ADAMTS13 plasma activity, either because of hereditary deficiency or acquired antibodies against ADAMTS13. And hemolytic syndrome, you all would have heard of hemolytic syndrome. This is another thrombotic microangiopathy, mainly involving the kidney. And they could have neurological or cardiac involvement. Okay. HUS is usually related to Shiga toxin, diarrhea by Shigella infection. The Shiga toxin damages the endothelium and then leads to hemolytic uremic syndrome. There is something called atypical HUS, which is caused by dysregulation of the complement alternate pathway, and that is not. That is also seen during later half of pregnancy or in postpartum period. In preeclampsia and eclampsia, you're all aware. I needn't talk about it. And catastrophic antiphospholipid antibody syndrome, where there is occurrence of fulminant multi-organ damage involving brain, kidney, lungs, skin, etc., resulting from extensive small vessel thrombosis in the setting of persistent antiphospholipid antibodies positivity. It is usually associated with thrombocytopenia and mechanical hemolytic anemia, but the patients are very sick. They usually have multi-organ dysfunction. So why do we always discuss this TMA, thrombotic microangiopathy, in pregnancy? So because gravid endothelium is pro-TMA, there is an imbalance between the pro-angiogenic and anti-angiogenic factors like VEGF, PLGF are pro-angiogenic, and SFLT1 is anti-angiogenic, especially in preeclampsia where there is more of SFLT. So gravid endothelium is already kind of conducive for TMA. What happens in TTP? There is reduced activity of ADAMTS13. What ADAMTS13 normally does is it cleaves this ultra-large VWF, von Willebrand factor, multimers. So when there is low ADAMTS13, these VWF, ultra-large VWF multimers are not cleaved, and they attract platelets. They are hyperadhesive to platelets, and they form clots in the microvasculature. So that's how they form clots, and there is hemolysis, there is thrombocytopenia, and there is organ dysfunction. In atypical HUS, there is abnormalities in the alternate complementing pathway, which finally results in endothelial damage and then clot formation. Okay, so differentiating various thrombotic microangiopathies, be it preeclampsia bar HELP syndrome, be it TTP or HUS. So it is difficult to differentiate them on clinical grounds alone. You need a definite diagnostic test and some tests to exclude, some tests to rule in. So preeclampsia, the onset is usually in second or third trimester. I mean, it's always in second or third trimester, and they usually present with high blood pressure. They have proteinuria. Um, they could have neurological involvement, renal involvement, and LFT derangement. But the Adam TS level 13 is more than 10%. Because in normal pregnancy also, even in normal pregnant women, as the pregnancy progresses towards the end, there is some reduction in the Adam TS levels. more so in preeclampsia. But in patients with TTP, the activity is less than 10%. So in preeclampsia HELP syndrome, RMTS levels will 13 levels will be a bit low, but it will be more than 20%. So HELP syndrome, they have thrombocytopenia, microangiopathy, but the clinical context is they usually present with hypertension and proteinuria. Whereas TTP, they can present in any trimester of pregnancy, but it is more common in second and third trimester or postpartum. Hypertension is not usually present. Neurological symptoms, in fact, that is the usual presentation TTP. The patient present with weakness, some headache, vision disturbances, etc., or some other neurological manifestations. Renal involvement is less common in TTP. They also, besides neurological, they may have cardiomyopathy. LFT derangement could be there, mild to moderate. TTP, the diagnostic criteria is very low, ADAM-TS 13 level, less than 10%. Of course, they have microangiopathic hemolytic anemia. They have moderate thrombocytopenia, moderate to severe thrombocytopenia. Platelet count is often less than 20,000. And the treatment of choice is plasma exchange therapy. And atypical hemolytic uremic syndrome, it usually presents in third trimester. It can present in any trimester, but usually presents in third trimester or postpartum. Hypertension is not usually present. They could have some amount of hypertension, but not common. Neurological symptoms are rare in HUS, unlike in TTP. Renal involvement is usually severe in HUS or atypical HUS. Patients are usually oliguric. LFT derangement is again uncommon in HUS. RMTS 13 levels are above 20% in HUS. Of course, they have microangiopathic hemolytic anemia and some amount of thrombocytopenia. Some patients could have normal platelet count also in HUS. Okay. So coming back to that, come back to our patient on PND 8. She had persisting or worsening thrombocytopenia, persisting microangiopathic hemolytic anemia, drop in HB, persisting LDH elevation, and then peripheral smear showing a lot of cystocytes on PND 8, despite treating her urinary tract infection adequately. So, but she had no other organ dysfunction. She had her vision disturbance were improving. She had no neurological symptoms like ataxia or headache, etc. And creatinine was normal. Her LFT was normal. Her edema was improving. So she has persisting microangiopathic hemolytic anemia, thrombocytopenia, but no other organ dysfunction. So to call it TTP and do plasmapheresis for her, we thought it would be an overkill, because plasmapheresis, we have to then put a triple lumen catheter. For that, we'll have to give her a lot of platelet support, because her platelets were 20,000 on PND postnatal day 8. We would have to give her a lot of plasmas. But she, except for thrombocytopenia and hemolytic anemia, she was otherwise stable. So the decision was just to put her on steroids, oral steroids, and then monitor her closely. So on postnatal day 8, we started her on prednisolone 40 mg once daily. Her body weight was 71 kgs. And we changed the antibiotic from amikacin to meropenem. And the next day, postnatal day 9, her hemoglobin remained stable and her thrombocytopenia started improving. And on PNG 8, postnatal day 10, her hemoglobin remained stable, platelets were improving further. And then we discharged her on tapering dose of oral steroids, B12 folate supplementation, and IV antibiotics, ertapenem 1 gram IV once daily. So this is PND 8, where the hemoglobin dropped, platelets dropped to 20,000, and we started steroids. We gave 1 PRBC on that day. On PND 10, the HB was 7.7, so basically it remained stable over the next 2 days. Platelets started improving, 20, 60, 80, and the LDH started coming down. So we discharged her on PND 10. And then subsequently on postnatal day 13, her hemoglobin started improving. Her thrombocytopenia was On the improving trend, platelet count was 1.2 lakhs, and her LDH started coming down 800. And on postnatal day 22, when she was only on 10 milligrams of oral prednisolone, HB was 10.8, platelets were 3 lakhs, creatinine was 1, LDH was close to normal range, SGPT was normal. So at this point of time, we've advised to stop steroids and then repeat her parameters a week later. We also told her to do the APLA screening lupus anticoagulant, anticardiolipin antibodies, anti-beta 2 glycoprotein antibodies 6 weeks from delivery time. We also told her to give ADAM TS levels because we could not completely rule out TTP, though her presentation was not completely typical of TTP because she had no organ dysfunction. Without plasma exchange, she started improving. Occasionally, we don't know, rarely cases of milder forms of TTP could improve with steroids. Anyway, we wanted her to do the ADAM-TS levels because if she has TTP, then her next pregnancy management would differ. So there is something called a plasmic score, which is a simple thing which involves basic clinical parameters like creatinine, MCV, LDH levels, etc. On that, she falls into high probability of TTP. But even a patient with HTP, HELP syndrome would, if you do plasmic score, they would fall into intermediate to high category of TTP. So summarizing, the hemolytic uremic syndrome and thrombotic thrombocytopenic purpura, they are very rare in general, and they are also rare in pregnancy. But if you, they need specific treatment in order to save the patient. If you miss the diagnosis, we may lose the patient or they will have long-term consequences. Most disorders have a clinical spectrum. See, whenever we discuss, we talk about TTP, HUS, HELP syndrome, we put them in boxes and saying, this value has to be below that. But in reality, the patient's clinical spectrum always, they do not fit into the boxes or columns classified by us. So it's important to look at the context. Context in this patient, she had preeclampsia, she had nephrotic range proteinuria, and the BP started improving, stabilized after delivery. The proteinuria edema started improving. It's just that she had persistent hemolytic anemia and thrombocytopenia, which is atypical for preeclampsia, because after 3 to 4 days, we would expect that improvement. So the context is more in favor of preeclampsia here. So whenever we have a patient with a complex disorder, patient with renal involvement, hematological involvement, look at the clinical context. That will give clue to your most likely diagnosis, preeclampsia, TTP, or HUS. And look at the clinical course after delivery, especially the trend, how the parameters are improving. Consider all possible differentials. And response to therapy, of course, adds to the diagnosis, but it's a retrospective luxury. And always consider baseline parameters while making a diagnosis. In this patient, her baseline systolic was 100 when she had thrombocytopenia, proteinuria, vision disturbances. For about a week, she was not started on antihypertensives because her max BP was about 136 by 86. But if you look at her baseline blood pressure, which was 100 by 70, there was a significant rise. I would have considered starting antihypertensives at this point of time. In first week of October itself, probably considered preeclampsia, started evaluating for alternate diagnosis, and then think in terms of delivering her at that point of time itself. Thank you.
Thank you, Hari.
Just 1 minute. So whenever you have a difficult patient, you have certain differential diagnosis. Always put them in this order. First, among the differentials you have, place a common disorder with typical presentation as your first possibility. Then atypical presentation of a common disorder as your second possibility. Then only you consider typical presentation of a rare disorder. And the last one should be atypical presentation of a rare disorder. In this patient, I feel she had preeclampsia, which is a common disorder, but the presentation in the course was atypical. Even for a TTP, which is a rare disorder, in our patient, the presentation was atypical of TTP. So that would be my fourth differential. Thank you.
Thank you, Hari. I think challenging on many fronts. And I think one of the things I would like you to address maybe a little bit after we discuss is how you actually counseled the family and kept them on board this course, because that would have been quite challenging, with not being sure of what we were dealing with, as well as the need to shift her through two hospitals causes a
Mm.
lot of anxiety. And how we communicate to the family is, I think, uh, an equally important aspect and challenging aspect of this case management.
Okay.
While I
Actually,
agree, so we'll come to that, but
uh, l-
uh,
yeah, yeah,
I just wanted to highlight that fact.
yeah.
So maybe if you can stop sharing, we can have a quick round of discussion. So one of the things I felt, and Lakshmi and you can both come in, that we see this often that people are started on aspirin and heparin. Aspirin, at least I can understand when you see high resistant, if you're not doing a formal preeclampsia screen. This lady didn't have a formal preeclampsia screen. But once somebody is on low molecular weight heparin, may not have been totally indicated, and then you see a drop in platelet. Um, I'm not quite sure how, I don't think that would have impacted the platelet uh,
Yeah,
counts, but still, it complicates the issue when you have them on a uh, low molecular weight heparin. Without a clear indication, this woman was started, isn't it, on low
yeah,
molecular
yeah.
weight
Yes, ma'am.
heparin. Um, And the second question I had was the response to her drop in platelet count, giving her an SDP before
She,
the steroids. I felt there itself there was a little bit of lack of clarity in
yeah,
management. What are we
yeah.
dealing with? They hadn't arrived at a diagnosis,
Diagnosis.
but there was a knee-jerk reaction to treat a platelet count, which is a lab
Yeah,
parameter,
yeah.
rather than evaluating what the primary problem was. Um,
So
right?
from 1st to 17th October, it was all outside.
I
So
no, no, I
most of the
understand.
things, yeah, yeah.
But just to
So
evaluate,
yes,
like when you
yes,
critically evaluate the management, I'm not
yes,
saying we
yes.
we could have done anything different. Lakshmi, do you want to come in on that as
Uh, Thank you, Uma, because I just wanted to fill in just one point when you mentioned about the uterine artery and the heparin and aspirin. I fully agree we should not give heparin without any indication. Not
mm,
only does it have other medical ramifications, it's also an expensive medication. So it's a big
mm,
cost implication to patients too who are paying from their own pocket. And I
mm,
think just for the benefit of all of us to be on the same page, if you're only using uterine artery as an indication to put somebody on aspirin, we should take the average PI, pulsatility index of both, because almost all
mean
graphs
PI?
will have a left separately and a right separately. And when we see a left which is high or a right that is high, just one being high is not important. So the average
Yeah,
pulsatility index must always be taken as a parameter if you're talking about a high uterine artery Doppler. Notches and things like that are no longer an individual indication. I just thought it will be helpful for us to be all on the same page for that. And
agree.
even in that situation, there are many algorithms we can use. For example, the Fetal Medicine Foundation has got a free online algorithm which we can use, where we can put clinical parameters and then put them on aspirin. I think that's quite important so that we avoid iatrogenic unnecessary medications. I think that's what I wanted to agree with
Mm.
you, Uma. And yes, in terms of her moving places and evaluation and all that, what I was also going to pitch in is, at what point would we all agree that she must be an inpatient? Because we're talking about a person who's got visual impairment, isn't it, as a symptom? When would we want her to definitely be an inpatient? When would we manage her as an outpatient? I thought that's one other aspect that we could explore as we went down the retrospective reflection.
I don't know what Hari thinks, but I feel in somebody like that with a very atypical presentation, um, even though her blood pressure was not high, I think that was the reason she was not. Um, she was the probably preeclampsia didn't figure in the initial evaluating team's diagnosis because she didn't raise her blood pressure above 140/90. and an ophthalmic, independent ophthalmic diagnosis was made, isn't it, Hari? So,
Yeah. So the problem was there was no unifying hypothesis for a diagnosis.
exactly.
Eye problem, ITP, then hypertension you started. So like if you put them together, we would want her to be inpatient because the moment you have such low platelets and you have proteinuria and then even mild
Yeah,
hypertension or closer to that, our first diagnosis, the common things first, my first diagnosis would be preeclampsia. Keep her as an inpatient until we arrive at diagnosis.
and
And if
then
you're not able to make a diagnosis, I would have considered termination at that point
right there,
itself.
exactly. And maybe that prolongation of 10 days could have also been what has extended her
Extended.
condition later. If she had, I mean, if we had realized there was a significant maternal disease fairly early on, 24 weeks of pregnancy, where we are
23.
really not 23, where we are not looking at salvageability. That may have been a point to have that discussion.
Yes.
So before we move on, the other thing I wanted to highlight is very often LDH is not done as a part of LFT. And in a lot of places, they do liver function, but liver function tests in most labs don't include an LDH. And therefore, you don't have that additional guiding value to suggest is this hemolysis happening, not happening. And many times the smear is not done, so you don't see so these two are important to say hemolysis is happening, and oftentimes these two are not done, and then we are stuck because it gets picked up later and not in the initial assessment. And my other question was, with the benefit of hindsight, I know you said we didn't order Adam TS because it's expensive and it'll take 10 days. But do you think it would have helped you?
Yeah. So actually, I think that was, I kind of was retrospectively thinking I should have just sent it off. The hematologist was like, anyway, we'll make a clinical judgment. It's not going to come in the next 10 days. But I think I should have sent it. I think, yeah, you should just send it. And then when you have the value, I've actually asked them to do it now.
Yeah, you said that. Yeah. Yeah. So I think you very beautifully walked through the different how the thought process should be at each point in time. And, we think about preeclampsia, we think about HELP, we think about TTP and HUS. But as you said, this one didn't fit squarely into any one box. But we still have to manage her and try and figure out how we are going to. So I think it was a very nice case to discuss because it helped you illustrate I think some very important learning points, isn't it? That we try and put the findings down to try and make a diagnosis. You don't knee-jerk treat one lab value because, I mean, really that SDP, I feel, she was not anywhere near delivery or an intervention at that point.
Yes.
You could have steroided her first instead of giving the SDP because SDPs are precious commodities and you don't want to waste that resource. And maybe there was hemolysis going on even then. We don't know because we don't have an LDH and we didn't have a peripheral smear.
Yeah, we don't have.
Yeah. So any other final points, Lakshmi or Hari? Otherwise we can.
Uma, I just thought as much as this case demonstrated need of hematology, physician, obstetrician, perinatologist, fetal medicine, I think neonatal input is also quite important when we cross 24 weeks because we are talking about viability and now a lot of frontiers have changed and there is viability possible. Surely the smaller the baby, and especially a baby with Doppler abnormalities, will quite often not make a vaginal birth and come out in good condition. So I think the decision of a vaginal birth or an operative delivery becomes very tricky in the situation, because we are dealing with a hematological condition where operative interventions are going to significantly increase hemorrhage risk too. But I
Absolutely.
think having come this far, to completely be on board with the neonatal team, which is of a level 3 expertise, and then take a decision, will do full justice to these patients' outcomes. And I think that's one part that I just thought we can sort of put as
totally
a
agree.
comment
I agree, especially if this had happened at 27, 28 weeks, for example. I mean, in this case, we were at 24, 25 weeks when the decision to deliver happened. It could have easily been at 27 to 28, then the dilemma is stronger. I think, yes, even in India, in tertiary units, salvageability and survival is happening. But then there are so many other issues that come in, Lakshmi, the cost, is it all of those concerns. So yes, a neonatal discussion and having the parents on board, which I'm sure did happen, but is something that we need to be cognizant of. Yeah. And family counseling, I think having them walk with you while you held their hands through 3 weeks could have been quite challenging, isn't it?
Yeah, so I was from 22nd of October, they're still under my follow-up. They send me the reports, they call me. So a lot of doctors in the family. So morning, evening, I used to actually explain the differentials. So this doesn't fit into anything. And actually they were very receptive, because their doctor's family, they kind of understood the diagnostic dilemmas, and they were on board with us. They were okay. Fortunately, she was stable with all the lab parameters were scary, but she was clinically improving. Her vision was improving, so patient was happy. She was,
so they were
and
probably less stressed.
Yeah. If there was organ dysfunction, like say oliguria, renal injury, something like that, then I do not know. But fortunately for us, the patient was stable. That's why we didn't rush for any plasmapheresis. We just wanted to sit tight, monitor her closely. Just made the decision for steroids because it was PND 8.
Correct. No, I think very well handled. And also the lack of significant renal dysfunction. So why you wouldn't think of HUS so much in this case, isn't it? For so much of hemolysis and thrombocytopenia, I think creatinine never exceeded 1. So,
and it started improving actually
improving
after
quite quickly.
Yes.
Anyway, so a lot of learning points, and thank you for sharing this case with all of us. I think we've all learned listening to the.
No, it's a good learning for us also.
Yeah,
it is a case which is like very. I don't know how it was managed. Whatever, no comments on that. But the course is very atypical. But finally, I personally feel it is preeclampsia with atypical presentation course. Probably like as you rightly said, the delay in delivery probably prolonged the course to some extent, and then there was intercurrent infection as well.
True. Okay. I think we will take
I just want to also comment that because she didn't develop hypertension afterwards, no, she remained controlled on nifedipine.
On 2 drugs.
Okay, so she's still on 2 drugs, isn't it?
Now she's off the drugs. Okay. Now at this point of time, she's off both the antihypertensives. She's now more than 3 weeks postnatally.
Okay.
But this will be a patient who will need pre-pregnancy counseling once we have everything in place, isn't it? Because it's going to be a very big discussion at that point.
On how to manage the next one, how to plan and manage. So the APLA screening, the Adams TS, all of that will help us with counseling her going forward. Okay, I think with this, we will now take a break and then come back to discuss the next case.
Thank you.
So I hope you can hear me. Dr. Lakshmi is also here. Dr. Lakshmi, I think we'll take the questions after both the cases. And
yes.
And Dr. Lakshmi, the questions I think are based on the discussions for these two cases, right?
Yes, yes,
Yes.
yes.
So,
The
so
questions
everybody
that we
can
have,
go
sorry,
ahead.
the questions are in the chat box, but let us finish both the cases and then take them on. Is that
Yeah.
okay for
Yeah,
the
that's the
audience?
plan. Yeah.
Yeah.
So also, I just want to tell the participant, doctors, that the second case is a shorter case. And after that, we have a quiz. And of course, the 3 winners will be given a certificate and also an additional discount. But I just want to tell you, don't go away because our break is just for 3 minutes. So we are going to come back immediately after that.